Good morning. This is Madras Medical Mission, Chennai, India. I'm Dr. Shivakumar, and we have an interesting patient for a live intervention today. This is a girl of around 12 years who has post-tetralogy branch pulmonary artery stenosis. So we'll look at now the PowerPoint presentation. This 12-year-old girl was diagnosed to have Fallot's tetralogy at birth. She got operated at 2 years of age with a transannular patch repair of the right ventricular outflow tract. There was a very thick stenotic dysplastic pulmonary valve which had to be excised completely. And then the surgeon placed a monocusp pericardial pulmonary valve. He hand fashioned a monocusp pericardial pulmonary valve. The patient had, please go back. The patient in the postoperative period had a complication of subglottic tracheal stenosis, which needed a balloon dilatation of the subglottic area and cryoablation of the fibrotic structures that were around the subglottic area. On follow-up, the patient was progressively identified to have severe distal main pulmonary artery stenosis. The echocardiogram showed a right ventricular systolic pressure of close to 90 millimeters of mercury. She underwent a cardiac catheterization way back in 2016, where the gradients were around 30 to 35 millimeters of mercury and the RV was 2/3 systemic. Currently, she is increasing effort intolerance, increasingly becoming breathless. She is currently weighing around 34 kilogram. A 12-year-old girl weighing 34 kilogram. The chest X-ray shows heart size of around 55%. Pulmonary vascularity is normal. This is the right ventricular 4-chamber view showing a tricuspid regurgitation and a moderate moderate dysfunction of the right ventricle. We can appreciate the dilatation of the right ventricle and the dysfunctional right ventricle. This is a parasternal long axis view, and this parasternal long axis view shows the right ventricular outflow tract is showing calcium in certain areas, and there is a free pulmonary regurgitation. This is a CT scan which shows a dilated right ventricle. When we see this movie running again, we can appreciate that there is a distal main pulmonary artery as well as right and left pulmonary artery origin. During the next cardiac cycle, you will again appreciate it. When this CT runs once again, we can now notice that there is a branch pulmonary artery beginning stenosis. When we concentrate on the still images, this is the dilated right ventricle in a multiplanar reformatted view. RV is looking larger than the left ventricle. This is the congested inferior vena cava indicating systemic venous congestion. This is the distal main pulmonary artery that is narrowing. What you are seeing in the center is the bifurcation of the pulmonary artery. Just before the bifurcation, the pulmonary artery is as small as 12 into 8 millimeters. And then when we see a little proximal to that, where the right ventricular outflow tract is a bit healthy, the distal main pulmonary artery that needs to be enlarged is close to about 2 centimeters. This is the measurement that has been taken in again a multiplanar reformatted view. When we analyze the branch pulmonary arteries, the right pulmonary artery at the hilum is looking very roomy, almost close to 14 millimeter, but at the origin is only 6 millimeters. The left pulmonary artery at the hilum is 14 millimeter and the origin is 5 millimeter, indicating severe bilateral branch pulmonary artery narrowing as well as distal main pulmonary artery narrowing. The important is to analyze the length of these pulmonary arteries. The right pulmonary artery is measuring almost as long as 35 millimeter and the left is measuring as long as 30 millimeters. This is the region of the distal main pulmonary artery. The tight very narrowed portion of the distal main pulmonary artery is as small as 7.5 millimeters. In any of these right heart interventions, we need to see the distance between the left coronary artery, because the left coronary artery sometimes gets compressed by the stent angioplasty. Here, fortunately, the coronary artery is far away. When we see the distance between the narrowing of the main pulmonary artery to the coronary artery, it's at least 10 millimeter away, and hence probably the coronary arteries are far away and they are not at the threat of any compression, extrinsic compression during this right ventricular outflow tract stenting. This is a volume rendered image. If you see the picture on the right side, you can appreciate the pre-bifurcation severe stenosis associated with narrowing of the right pulmonary artery at its origin and left pulmonary artery at its origin, and the hilar part is well expanded. So there is a sharp kink of the left pulmonary artery as well. There is a severe narrowing of the origins of the right and left pulmonary artery with a narrowing of the distal main pulmonary trunk. So our plan is to relieve this obstruction. So I will show now the fluoroscopy images from the beginning. This is show the first picture, fluoroscopy, the first image. So this is the catheter crossing. See what we do in these patients when we try to cross from the right atrium into the right ventricle, we try to avoid trapping the tricuspid valve chordae. One of the way will be to use as balloon flotation catheters, which will ensure that we don't pass through the tricuspid valve chordae. However, yet another method is taking an end hole catheter, forming a complete loop in the right atrium across the tricuspid valve, and make the loop of the right coronary artery cross the tricuspid valve rather than the tip of the catheter crossing the tricuspid valve. In the same view, we can appreciate the calcification in the superior edge of the right ventricular outflow tract, which was part of the pericardium that was used to fashion the transannular patch. On the CT scan, we identified that this calcified region was not the place of narrowing, and the narrowing was distal to this calcified place. And so that is going to be our fluoroscopic landmark on a lateral view. Once we achieved this, the right atrial pressure was close to 11 millimeters of mercury, indicating significant systemic venous congestion. The right ventricular pressure was close to 100 millimeters of mercury against an aortic pressure of about 135, indicating RV pressure is almost more than 75% of the LV pressures. And then the next picture. From here, we advanced the catheter into the left pulmonary artery, and we had parked an Amplatz superstiff guide wire. The distal left pulmonary artery pressure is 25 millimeters of mercury, thereby giving a gradient across the outflow tract of close to 75 millimeters of mercury. Another catheter was advanced through the same sheath. We have a 12 French sheath in the right groin, and through the same sheath we have taken a second catheter, and the second catheter is now going through the right atrium into the right ventricle, again using the same technique. Rather than crossing the tricuspid valve with the end of the catheter, we are crossing with the loop of the right coronary artery. And then the next, we advanced this catheter into the right pulmonary artery. So this is going into the main pulmonary tract. And from the main pulmonary, we advance the guide wire into the right. And the catheter also goes into the right. Next picture. So that is where we are. So the right and the left pulmonary artery pressures are around 25 millimeters of mercury, and the aortic pressure is close to 135 millimeters of mercury. Right ventricle was about 100. So our plan now will be to do some angiography. So for that angiography, what we are next going to do is take a 6 French marker pigtail. What is this pigtail? 5 French. Okay, 5 French. So hold it. So I am going to advance a marker pigtail, which will enable us to have a measurement marker. Holding. And through the other catheter, we'll advance the pigtail. This pigtail catheter now will be used for a distal RVOT angiography. We may be targeting three views, an apicaudal, an epicranial, and a lateral view for the initial angiography. So we have crossed into the right pulmonary artery. I will straddle across the right pulmonary artery, keep it inside the loop. Let's go to epicranial here. Yep. Yeah. So we are making one angiogram. Come a little towards me. So we are going to make an angiogram with 25 ml of contrast at 15 ml per second across this outflow tract. Let's freeze it now. Go back. Yep, that's it. Next picture. The previous one. The previous one. Okay, this delineates the distal narrowed main pulmonary artery, the origins of the right and the origins of the left next frame. So there is a sharp kink of the left pulmonary artery which you can see as an overlapping contrast. Let's get another view here. Go to lateral. Full lateral. The patient is being maintained on a laryngeal mask with sedation by our intensivist Dr. Uday, who is managing the airway. And with me helping for the procedure is Dr. Vishnu and Dr. Ashok, who are our senior fellows. Okay, now little more, about 100 LAO. Yeah, that's fine. So ready for injection? We can appreciate the calcium in the right ventricular outflow tract in this view. The place where there is calcium, the right ventricle is widely open. We have a very short segment of the main pulmonary artery which is narrowed before the pulmonary artery branches into the two vessels. So our plan will be to get in a main pulmonary artery stented at its bifurcation. So for that, we are going to now advance a Terumo wire into this. Come to AP view. A Terumo wire into this right pulmonary artery. Exchange this for a right coronary artery catheter, RCA. As I told earlier, the outflow tract gradient across the main pulmonary artery and the origins of the branch pulmonary artery is almost close to 75 millimeters of mercury. So we are advancing this. We'll try to get a guide wire position a little lateral. This also looks reasonable. So let me go in here itself. Okay, Lunderquist wire. So this is a Lunderquist wire in the right pulmonary artery and an amplat superstiff wire in the left pulmonary artery. I am removing the marker pigtail. We now need a sheath that will go through both these wires. So there is a particular type of sheath. I'm going to demonstrate that sheath. Give me saline. So this sheath has got a peculiarity that it has got two guide wires. So there are two guide wire ports. So we are going to be taking out that 12 French sheath. We are going to take out this 12 French sheath over the two wires will be retained and the 12 French sheath will be now taken out. So one of this wire, hold it. One of these wires. So one of the wire goes into one of the lumen. And the other wire goes through the other lumen. This particular sheath allows us to do a bifurcation stenting get me a blade and a small artery forceps so that I dilate the groin. Keep the blade safely back. So now this sheath goes over the two guide wires. So now this is advanced. The two should come together. Hold it. Keep the two together as I'm advancing. Keep the two together as I'm advancing. So we are progressively advancing the two. This two needs to be kept together. The two needs to be kept together as I advance the problem that we are facing currently is that the uh, the dilator is not able to manipulate its way. So what we'll do is we will now switch over, show the other guide wire position. Yeah, so I'll get the LPA wire deeper. I'll remove this Landerquist wire now. I'm taking out the Landerquist. I'm taking out this dilator, holding it. And I'm switching over to a single lumen dilator. The original attempt was to get a double lumen dilator deep inside to reach the bifurcation. However, the sheath tip was protruding, the dilator tip was protruding towards the outflow tract, which did not allow us. So we are going to plan B, which will be using a standard dilator which is a single lumen dilator. Can you control the wire there? So this is a single lumen dilator which I am advancing across the outflow tract. Leave the wire. Now at this point, while Dr. Vishnu is holding the sheath, I am taking a right coronary artery catheter with a thermo wire, and we are going to cross into the other pulmonary artery. The right coronary artery will go parallel to this wire. The right coronary artery catheter with the thermo wire we have to enter the right pulmonary artery here. Can you show me that position? The epicranial angiography. So here we can appreciate that the right pulmonary artery is arising just above the sternal. Can you get into the same view, 42? So we are quite above that. So that's probably the reason why we are not able to cross. So now I'm withdrawing the catheter. So this is the right, going deeper. Now let us come to AP projection. So this is, I'm now going to get the Lunderquist wire into the right pulmonary artery, center the heart. So now we have two wires, one going to the right and one going to the left. The Lunderquist is going into the right and the Amplatz superstiff is going into the left. Here. We'll flush this line now. I need some contrast on table to get one picture of the distal main pulmonary artery. So what I have done is I have layered contrast so that the last 7 ml is contrast and the remaining part is saline. Go back to that same view cranial projection 42. We have to now see what is the relationship of the bifurcation. So this we are almost at the bifurcation. So Gospies, please. Freeze that image. Correct. So this is the location where we are now having that narrowed distal main pulmonary artery. So the position of our common bifurcation stent has to be exactly in this location. So what we are going to do is something called as a double balloon single stent strategy. So we are going to be mounting two balloons, two Admiral Extreme 12 into 4, two Admiral Extreme 12 into 4. I'll demonstrate the way in which we mount it. This is a 12 millimeter diameter, 4 centimeter stent. I need two indiflators. We need a crimper ready. So these are the two balloons. So both the balloons are, what is the length of these two balloons? 120 centimeters, thank you. So now what we are going to do is, we need 2, 3, 5 wires. Can we get this 3, 5 thermo wire? I want that intra stent LD max 26 centimeter, 26 millimeters. Can you put it into this wire, Lehman? Not that. Here. So this is an intra stent LD max, which is an open cell stent which can be dilated up to 25 millimeters. I'll dilate it initially with a short dilator. I need a little larger dilator, maybe something like an 18 dilator, so that we are going to mount both these balloons. Crimper ready?
Yes, sir.
So we have a dedicated crimper for this. a larger 18 millimeter dilator. This is 18 French. This is to enlarge the stent so that both the balloons can go inside. So we are doing what is called as a double balloon single stent strategy. Okay, get another wire, 3-5 wire also through the other one. So now we are centering the two balloons and then keeping the stent in the middle. This is a 26 millimeter stent, and so now we are crimping the stent now. Press it here. We'll see a fluoroscopic appearance of these two now. Come to AP. So the two are the stent is slightly positioned proximally. We'll again try to crimp it a little bit more. We are now putting in a sleeve, a 14 French sleeve, which will be protecting the two stents. And now we'll take out both the wires now. Wire has come out. Has come out. Okay. The second will go through the second balloon. Show the light here. Both are out. Again, I'm rechecking both. I'm covering both. Both wires alone, you hold it. Both are Admiral Extreme 12x4. So we are advancing both systems through this sleeve. I'm getting both the stents passed deeper. And now I'm withdrawing this sleeve out. So now both the wires you're holding. So now I'm slowly advancing the system without giving any tension on the Now let us fluorostore this and show the tapicranial projection. I want two indiflators, full contrast. Come here, Ashok. So this is the, show that same cranial view. One by one connect it. So here we are advancing this assembly deeper. So that it goes almost into the bifurcation. Hold the two wires together. At this point, I'm going to make an angiography. With the side arm of the sheath, I need a discard bowl. So we are trying to identify the distance between the bifurcation. Let's carefully analyze this picture. It'll be nicer if we go a little bit more deeper. So I'm going to hold the two wires like this. This lifted up. This hand can come out. So I'm trying to go as distal as possible. Can you hold this? I'm going to make another injection. We're pretty close to the bifurcation. Our intention will be to expand the stent. Let's try to get the right and the left pulmonary artery to bit separated. So let's go to about RAO 40. And cranial 40. Our intention is to separate the right and the left and see both the ostia separately. So the patient's face is getting exposed, and so tell the anesthetist, yeah, face can be turned to the, maybe the chin up so that, okay, more cranial and collimate the chin part, collimate the, okay, that's fine. That's fine. Yeah. So here let us make an angiogram and see how far we are from the, we are almost on the bifurcation. If somebody can hold the head in that position, then this will be, we can recheck.
More contrast. Contrast, Surya.
So we are trying to find out the separation of the two pulmonary arteries. Let me try to go a little bit more deeper. Okay. So hold it here. We have almost reached the target. It's in the most distal part of the pulmonary artery. The left is going superiorly, right is going inferiorly. So at this point, I'm going to connect to, this is connected to the indiflator.
This is not connected.
The second one also will connect to the indiflator. Okay. You hold it. Now you have to go up and, okay, you are controlling the wire.
Yes, sir.
Sister, you take one indiflator. Both of you should inflate together. Both of you should inflate together progressively. Keep inflating. Keep inflating.
3, 4, 5.
Keep inflating. What is the burst pressure? Huh? 11. Go to 11. Go to 11. Go to 11.
Go.
11.
8.
11. Are the other person also go to 11? 11. Okay, deflate both. Deflate both.
Fast.
Fluoro store this.
Pull back. Yeah.
Fluoro store this. Show the stent now. The aortic pressure is low because we had occluded the outflow tract. Both the balloons should be deflated fully. The pressures are slowly picking up. I will now deflate, empty the balloon, empty the indiflator and empty this one. So now the balloons are deflated. That's an empty deflator. Okay. Give a full negative. Empty that also. Come to APVO. The blood pressure has completely picked up. So we are going to give a negative. We are going to go back to the same view and see the position of the two stents. Both the balloons are fully deflated. We are at the bifurcation, and the proximal part of the stent is in the dilated portion. and the narrowest part of the stent is across the bifurcation. So at this position, we are going to take out both the balloons securely. Can you control it? So I'm going to first take out the balloon from the Lundquist. Can you fluoro? Out?
Yes, sir.
Out. Now control that wire. This balloon comes out now. We are going to now take an 18 millimeter Atlas gold balloon to widen out the distal part of that stent. The second, now we are going to take out the left pulmonary artery balloon also. (18 to Atlas gold). Again at this point, we're going to loosen the tension on the, just hold here, so that we make one check angiogram. So this is the check. The contrast was feeble, so I will make another injection. Okay, so we are able to see the, freeze it now. Yeah, so the distal part of the stent is almost at the bifurcation. The right pulmonary artery is coming below and the left pulmonary artery is going above. So we will post dilate this with an Atlas gold balloon. Flush the central lumen. We will take the Lundquist wire.
Let go.
Okay. Connect a larger. Can you prepare the balloon there?
Yes, sir.
Okay. You hold both the wires. Yeah. So now I am advancing
To
this
be prepared. Which balloon need to be prepared?
Atlas gold.
One more balloon.
Leave the wire. So we are at the level of the stent. Now I need a 20 ml syringe with diluted contrast. A three-way should be there.
Cut it in clip.
So I'm de-airing this balloon, the indiflator. When I turn it around, you may have to be ready to do the inflation. Hold both together. So I'm slowly inflating the Atlas Gold. Keep it pushed forward. Keep it pushed forward. So now tell me the numbers.
8, 10, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30, 31, 32, 33, 34, 35, 36, 37, 38, 39, 40, 41, 42, 43, 44, 45, 46, 47, 48, 49, 50, 51, 52, 53, 54, 55, 56, 57, 58, 59, 60, 61, 62, 63, 64, 65, 66, 67, 68, 69, 70, 71, 72, 73, 74, 75, 76, 77, 78, 79, 80, 81, 82, 83, 84, 85, 86, 87, 88, 89, 90, 91, 92, 93, 94, 95, 96, 97, 98, 99, 100, 101, 102, 103, 104, 105, 106, 107, 108, 109, 110, 111, 112, 113, 114, 115, 116, 117, 118, 119, 120, 121, 122, 123, 124, 125, 126, 127,
So I'm trying to deflate the balloon. The BP is falling because of the outflow tract obstruction. So now we have taken out the balloon has been deflated. So now we are going to get this balloon slowly withdrawn. So that Atlas Gold is coming out, fluorostore. Run it again. This Lunderquist is, you are holding? Okay, this has to be inside. This has to be kept. Okay. Okay. So now let us get both the wires into a little deeper position. So now I need a Judkins right coronary artery catheter. Come to AP view. We will now consolidate the positions of the guide wires because the guide wires has come a little bit out. Can you get it into the Lunderquist wire? So we're holding it. So now I'm pushing the guide wire deeper. Now I'm taking out this catheter. Hold the blue. Come to the center. Get this right coronary artery onto the left blue wire. So now I'm advancing the amplat superstiff wire also deeper. So over both these wires now I'm trying to get the sheath closer to the stent. Now we are holding it there. Hold the Landerquist wire. Now we will take that 7 French long 90 centimeter sheath. Let me measure the right ventricular pressure at this point because we have done a angioplasty of the distal main pulmonary artery. So I'm now connecting it to the right ventricular pressure. Leave the wire. So this is the right ventricular pressure compared to the aortic pressure. We already have a substantial reduction in the right ventricular pressure to about 40 millimeters of mercury. Let's go to that cranial projection so that we have an angiogram. I need a 20 ml contrast syringe. Or else I think this cranial will be a better view. Let's get a picture done. I'm just filling my syringe. Is it possible for the chin to move out of the screen? If the chin of the patient to slightly move out of the screen. Take it fully inside. Now we are now having the stent almost in the distal main pulmonary artery. The origins of the right and the origins of the left are significantly narrowed, which we are planning to now address. So right now what we'll do is we will advance a long sheath on the left pulmonary artery, which is the amplat superstiff guide wire. Hold the. I'm now taking out the dilator out. Let's position a 10 into 20 formula stent on this now. 10 into 20 formula stent. I am de-airing this sheath. Ten into 20 formula 535. So connect the indiflator. Central lumen flush. Central human flush. Central human flush. Okay. Now connect the inflator to the side arm. Keep it straight and fix. So this will remain there. Now we do the same thing with the right side with another 7 French sheath. This is going to be challenging because we don't, this is 7 and 7 going through a 7 and 7 going through a 14 French sheets. So it's not permitting 2 sheets. So let me see that angiogram again. Yeah. The previous angiogram. Okay. Okay, now you hold control this one. I'm taking out this. Can you do fluoro? I'm taking out this sheath. Yeah.
Out, sir.
Okay. So now I will advance this guide catheter into this Lunderquist wire. It's also finding it tougher. So I will take it out. Get me a diagnostic 5 French catheter. Hold it straight and also having a lot of resistance. So what we'll do is we'll expose this stent and deploy the left pulmonary artery stent. Going to have an angiogram from the side arm of the 7 French sheath. So we are into the left pulmonary artery and partly protruding into the main pulmonary artery. Can we get that RAO projection again? We have connected this. Yeah. So get ready to go to about 10 atmospheres, 12 atmospheres when I tell you. Yeah. Can we Can we turn the face a little bit so that it comes out of the... Yeah, that's fine now. Now it's fine. So I'm going to make another angiogram to see. Yeah, it's covering the left pulmonary artery stenosis. So at this position, the sheath has completely come out. Can you go to 12 atmospheres? Yeah, 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 yeah. 12, 12. Deflate. Okay. So now I'm going to remove this formula balloon out and then do a check angiogram. In the meantime, I'll take out this catheter that we have advanced. So this catheter comes out. Now I'm going to withdraw the formula. This is full negative. So the formula stent has now come out. I'm making another angiogram through the side arm of this sheath. So that is the left pulmonary artery. Now we need to go into the right pulmonary artery. So what we'll do is, there was a sheath that we prepared already, the 7 French sheath. Now this one, I'm going to take it out. You're controlling the Landerquist wire. Hold it. Hold the sheath. So now I am taking out the dilator out of the right vessel. Another 10 into 20 formula. Second formula 10 into 2. Central lumen flush. Central lumen is here. Yep.
Waiting for the...
Thank you. So we are exposing the stent now, again using the previous landmark. So at this point, I'm making one angiogram. Tightening the check flow. Checking the position of the right pulmonary artery. So we are advancing the stent deeper. So we are expanding the stent here. Go up. "12, deflate." I need two Mustang 12 into 4 balloons now to consolidate. Once again, we can think about doing that Armada also, like 14 millimeter. Let's first I'll take out this and then we'll take a call. Okay, now I'm going to take out the balloon is fully deflated. Let me see one cine. Let me see one picture. Can we go to epicranial? Yeah. So there are two stents on either side. Let me take out this balloon out now.
Million north.
So now let me take the sheath also out. Control this guide wire. Both these 14 armadas are 7 French. So I should be able to get two armada balloons, 7 French through this 14 French combined sheath. So open the armada balloon 14 into 4. In deflator again. Remove those wet gauze pieces out. We'll get another drape. Can you remove that syringe? Hold the wire, please. Keep it straight and hold it. Can you hold this balloon? Get me another armada. Another armada balloon. Central lumen flushed. Central lumen. Yep. Connect this armada to an indiflator. A full indiflator here. Holding the wire. Both the wires to be held. Both the wires. Dry gauze. That stent has moved there. That right pulmonary artery stent has moved distally. See this? Allow the guide wire to go. So hold it. So the guide wire has moved distally. I will go distal to the balloon. Slightly grasp it. Slightly grasp it. I have grasped it. I'll try to bring it back into the RPA origin. Bringing it back into the RPA origin. So this is now, okay. Ashok, come here.
Sir.
So hold it. Control the two guide wires. We are going for a simultaneous inflation. When I tell you, go. Just hold on. Let me see the positions. Okay. So now I will just once check the cine. Don't inflate. So now we have got both the stents in the correct position. You are holding both the wires. Right, left hand holds the sheath.
Yeah.
You are going to inflate and you are going to inflate simultaneously. Both should go to about 10 atmospheres. Start inflating. Start inflating. The left person should start faster. Left person should start faster. Yeah. Yeah. Now both of you inflate.
2, sir.
Both of you.
4.
Yes.
6, sir.
Yes.
6.
Yes.
7,
Go
sir.
to
8, sir.
go to
8, sir.
go to 8.
Yes, sir. 8, sir.
Both of you 8.
Yes, sir. Right is 8,
8.
sir.
Both of you deflate.
Yes, sir. Deflated, sir.
Both of you deflate. Now there is a fall in the cardiac output because both of you have inflated the balloon. Both of you fully deflated. There's a significant bradycardia. Now its heart rate is picking up. So I'm taking out the right-sided armada balloon.
Sir, wire is coming.
Okay. Connect the ECG again. Okay. Now, the left one. Let me see the picture now. Take your hands out. Yeah. So now we are going for an angiogram for both. Hold it here. Show that angiogram. Freeze it and show. Freeze it. Correct. Just go back. One frame. Wonderful. That's enough. That's enough. So the left pulmonary artery is well within the previous stent, whereas the right pulmonary artery is about a couple of millimeters. This is a 2 centimeter stent. I'll now take only a cine. So it's a 2 centimeter long stent. So possible that there is about 2 or 3 millimeters of the right pulmonary artery origin which is still uncovered. However, show the previous picture. Yeah, freeze it. When the dye is fully there, freeze it. Yeah, go back. Correct. So this picture now looks quite adequate. So I'm going to first take out the second balloon also now. You're holding the Lenderquist. So I'm taking out the second wire also, second balloon. At this point, I'm going to advance the pigtail catheter. Pigtail catheter, not the marker, the other one. Let me also connect to RV pressure now. That's the RV pressure. The right ventricular pressure is significantly reduced. It's now only around 35 millimeters of mercury. It's 35. So quite substantial reduction of the right ventricular pressures from 100 millimeters of wire, thermo wire, to almost 35 millimeters of mercury, while the aortic pressure is more or less the same at around 130 to 140 millimeters of mercury. So now we are going to make little bit out. Advance the guide wire. Now, can you put in the stiff end of the guide wire? Or else, yeah, give the sleeve if it is there. Okay. Can you advance the guide wire? Advance. That's enough. Advance the guide wire a little bit. The Landerquist wire has come out completely out of the right pulmonary artery. So this is the main pulmonary. This is the pigtail across the LPA. Since the Landerquist wire has come out, I'm taking it out. Take it out. Let's be ready for one angiography now. The hemodynamic results are perfect. The right ventricular pressure has dropped from 100 to 30 to 35 millimeters of mercury, which is almost like a significant elimination of the gradients. Now we are going to give 25 ml, 30 ml at 15 rate. The chin of the patient can slightly move, or we can collimate a little bit. Correct. That's good. That's good. Ready? So we are making first angiogram in this view. Let's freeze this picture and observe. Yeah. Next picture. Yeah, correct. No, previous. Yeah, it's looking quite good. The RPA origin is slightly smaller, but we have to remember that we have dilated the hilar mediastinal portion of the right pulmonary artery with a 14 millimeter balloon. So now we have a 14 millimeter on the mediastinal PA. So visually, if I look at it, it's almost more than 75% at the ostia. So there is a fair amount of relief of the RPA. Of course, LPA is completely relieved. And we have a marked fall in the right ventricular systolic pressures. So I think we will come out now. Before coming out, I will just like get that proximal end of the RVOT stent a little better. Get me the thermo guide wire. What was the balloon that we used for the? Can we get a 20? So this is a 20 Atlas Gold that targets primarily the lower part of the stent. Can you flush the central part, central lumen? Central lumen. Yeah, that's it. That's it. Come, keep it straight. Straight. Yep. So now I'm trying to advance this to just the proximal part. We are targeting primarily only this proximal part. I need a full inflation. Yep. Our intention is only to dilate the proximal portion, so keep it forward pushed. Now go up. Tell me the number.
4, 8, 11, 10, 11.
Fluorostore this and run it again. Fluorostore this and run it again. So the aortic pressure again is picking up. Whenever we dilate the outflow tract, the pressures drop and then they come back again. So we have now consolidated the proximal portion of the main pulmonary artery to 20 millimeter, which means we are ready to go for a percutaneous pulmonary valve when this girl gets a little older. And this is negative. Okay. So now I'm going to take out this Atlas Gold. So now we need the Judkins right coronary artery catheter. Figure of 8 stitch. Leave the wire. So we are now in the left pulmonary artery, deep in the left pulmonary artery. We're going to make a pull back from the left pulmonary artery all the way into the right ventricle and right atrium. Okay, that is the left pulmonary artery. So the pressures are almost around, this is between 25 to 30 millimeters of mercury. It's crossing the 25 line and just below the 30 line. So between 25 to 30. So now we are progressively coming off. Now the catheter is going to come into the, that's the main pulmonary artery. More or less same pressure. It's 30. We are coming into the right ventricle. Show the right ventricle, come to AP view. Okay, so this is the right ventricle. So we have below the valve, below the stent, some amount of right ventricular, possibly an infundibular gradient. Lot of ectopics are there. So let me reduce the ectopic. Yeah, so I'll further pull it out so that, yeah, this is now, get it on to 600 scale. Yeah, now we have the right ventricle is about 58 millimeters of mercury. Now we are coming into the right atrium. The right atrium is around 12 millimeters of mercury. 12 millimeters of mercury. So look at that last angiogram. Show this first angiogram. That first angiogram in the same epicranial so that we get a corresponding. Yeah. So this is where we started, and let's that is where we started, and we have the still frame. Can you take a still frame of this? Yeah, go back. Next picture. Okay, so this is where we started. The right and the left pulmonary artery origins are significantly less than the 1 centimeter marker that we see on the marker pigtail. Now show this last angiogram on the same projection, the previous. Yeah, so freeze it now. Go back. Yeah, go back further. Correct. So there is a little bit back. Yeah, that's good. So now we are like in the early arterial phase of this pulmonary angiogram. There is a satisfactory increase in the lumen of the entire pulmonary artery. So at this point we are going to come off. Let me take one figure of 8 stitch in the groin. Scissor ready. Show the light. So we'll take a double layered figure of 8. This is just to reinforce the stitch integrity. This will be removed a few hours later. We'll give aspirin at a dose of about 150 milligram once a day for the next about 1 year. And at the end of 1 year, we will repeat another CT pulmonary angiography and assess the anatomical results. Over a period of time, now she's about 12 years. At some point of time, we will think about doing a pulmonary valve implantation into the stent that we have placed in the right ventricular outflow tract. So now keep taking it out. Scissor.
Scissor.
So the groin looks clean, not much of bleeding. Let's give some bupivacaine injection topical so that there is not much of pain. So what we saw now was a complex. Can we get one more fluoroscopic image of that bifurcation epicranial? So what we have done is yeah, narrowing of the main right on the left pulmonary artery. Just come down a little bit. So here we see the bifurcation of the pulmonary arteries and the distal main pulmonary artery corrected by stent angioplasty with good drop in the right ventricular pressure. So we got the bupivacaine ready. So we will give some local anesthesia in order to reduce the pain in the groin site. And we will, the patient is on laryngeal mask breathing. So she's on her spontaneous breathing. Airway is protected with a laryngeal mask. The sedation with dexmedetomidine that's going on will be tapered off now, and she will be sent back to the room by evening. As I suggested earlier, our protocol will be to give aspirin for about an year and then repeat a CT imaging by 1 year later. So thanks for the opportunity, and we'll meet you another day on another interesting session. Thank you very much. Goodbye from Madras Medical Mission, Chennai.